Good evening, and welcome to this special edition of Doctors on Call on the COVID-19 pandemic. I'm Dr. Paula Termuhlen, the Regional Campus Dean at the University of Minnesota Medical School Duluth Campus, and I am your host this evening. We're continuing this series of special programs to answer viewer questions about the coronavirus. For example, will there be a surge in new cases as the state begins to allow businesses to reopen? Our guests are here to answer viewer questions about coronavirus and our new normal, and once again, I want to thank everybody for sending us a whole bunch before we get started tonight. The telephone numbers and the email address for your questions can be found at the bottom of your screen. Our panelists this evening are Dr. Kathy McCarty, Professor and Associate Dean for Research at the University of Minnesota Medical School Duluth Campus, and Dr. Daniel Nikovich, oncologist with Essentia Health. I want to thank our WDSE staff for taking good care of us, and you'll notice that we're having appropriate distancing as we respond to your questions this evening. Members of our staff are also waiting to take your calls and emails, and so with that, let's get started with this week's discussion. So, we had that right off the bat. Do we think we're going to have a surge now that businesses are opening? What do you think, Dr. Nikovich?
Well, we may. I mean, the models that are in place would predict that we will. I haven't seen any models that would tell us not, and that's why we're preparing in every way that we are.
Well, and I know I saw another sort of a fact, if you will, around if 60% of the people wear their masks 60% of the time, then that actually helps us keep things sort of under control. So I think that's our pitch out there to say wear those masks when you're in public. And I know there's been a few rumors around talking about how masks might make you sick. Dr. McCarty, have you heard any of that?
I have heard some of those rumors, and I'm actually going to pass that to Dr. Nikovich as our clinician, but you do hear these rumors. Do you get sicker by wearing your mask?
I don't believe you do. I think if you wear your mask appropriately, that you won't. Some people will notice that they'll say it smells bad. That's maybe your breath.
Opportunity.
Yep, but no, it won't make you sicker in the way these things are designed. And in fact, the way those surgical masks are designed, and a lot of them, there's a charge factor in there that sort of traps the virus, not mechanically, but actually by electrostatic charge. And it's contained within the fabric of the mask, and then it doesn't go anywhere. It's very, very interesting design and how it works. So no, I don't believe you get sicker when you wear your mask.
Well, and I would agree with that, and I think the sort of tangent to that is we're really trying not to get sick. There's been a little bit of conversation around the idea that somehow if everybody gets sick, then we'll all have the immunity. And I think there's just so much we don't understand right now about this virus. That would be a very dangerous thing to do, I think.
I would agree. And as we're doing more testing and trying to understand the true prevalence of the disease, we'll know a lot more about it and its natural history. With the antibody tests that are available right now, they do not necessarily imply immunity. They just tell you that you've been exposed.
Right.
I think with the masks and all, one key thing I've read has been, if you think about masks, hand washing, social distancing, you have to have all of it. And if you slip on one, then there's going to be an increased risk of viral transmission, and you really have to be very diligent about having it all in place and committed to it.
Yep. So it's really reassuring when we head to the grocery store and we see folks wearing those masks. But we know that some people have been getting sick, and early on we heard about how facilities can be overwhelmed. And one of the reasons, or one of the things we wanted to talk about tonight a little bit, is how those decisions are made in terms of facility planning and the kinds of things we can do to reassure our community that we know what we're going to be doing. So Dr. McCarty, you and I were talking a little bit earlier about because I know you're on a panel for the state. What happens if we don't have enough ventilators? Like, how do we start to make those decisions? How are our health facilities preparing for something like that?
So we're hopeful that won't happen, obviously. And even in New York, where we saw that big surge already, they didn't actually have to go. They got really close, but they didn't have to go to rationing their ventilators. So at the state level, there's been a group that's come together from University of Minnesota, healthcare organizations, state health department to develop policies so that we agree amongst the state. It's been a fantastic thing coming together about how we would make decisions. And there are clinical criteria. The person who makes the decision would not be the physician, but somebody separate, so they don't have to have that bias in making that decision. Objective criteria, where we're looking not to bias against people who would be have problems socially coming into this that we just exacerbate.
Well, and I know there's been quite particularly about ventilators, I have to say that we know there's been some really wonderful work that's been done about creating sort of other alternative methods of delivering, the same type of support if someone's short of breath or having difficulty breathing. And that, I think, is also something that's been reassuring to see. But the whole idea that there's been thoughtful consideration about how to handle this so that we don't have to be in the moment, right, and make these decisions. Right. And I think as a community, both Essentia and St. Luke's here in Duluth have, as I understand it, are completely lockstep with how those decisions would be made so that patients don't have to feel that if they go to one facility or the other facility, there might be a variance in how they're treated. So, and I know our local regional, because we go out regionally here with the show, they are also involved in this process, right?
Correct, yep.
Well, and so that brings me to another area that there's been a little bit of conversation about is this drug remdesivir, which is the one drug so far that's been approved that they think there may be some, that there's some help for patients that are particularly ill. Could either of you talk a little bit about, how they're rationing that right now around the states, or?
And that varies by state as well. So guidance from the state health department just came out the 20th, May 20th, on how the criteria. And again, across the state, people don't have to worry that one hospital is going to be different than another one, or I'm going to have to choose hospital X or hospital Y, that they're all using the same criteria to decide who will get it once it comes to the state.
And it's going through state health departments who are then being able to distribute it. And I think that's really also reassuring, so that regardless of where someone might be in the state of Minnesota, our Minnesota Department of Health will help with that. And then some of the key hospitals I know have stock on hand as needed, but can trade that around. That's when people come together to really solve these problems.
And there's also there's priorities attached to it. There's different tiers that I know our guidelines are established in that one. I presume others are similar. And for example, a tier 1 use of remdesivir would be a patient who's intubated and sick, acutely ill with COVID virus. A tier 2, I don't believe they have to be intubated, but they're obviously seriously ill with COVID and have other clinical criteria present that would indicate this patient would benefit from that antiviral and therefore should be allowed to receive it.
Great. So here's another question. Dr. McCarty, I'm going to put this one to you. We had a question from an email, and this was last week, and so I promised to get to it. And it says, looking at the Minnesota Department of Health data, each age bracket, 20s, 30s, 40s, 50s, beyond, have had more cases than the elderly population. So do we know in that younger group, that we'll say 60 and younger, what percentage are requiring hospitalizations and ICU care compared to the older group?
Oh, so that's a great question. The numbers, you see so many different numbers at the state or the national level and how the numbers are presented. And I'm going to recommend a really good website. So how do you get accurate information? Our state health department, Minnesota State Health Department, has a fantastic website. Lots of visuals and graphs and things. So whoever's written in, thanks for that question. Yes, the absolute number of cases is much higher in the younger age groups. Because we have more younger people.
Ah.
Yes. In fact, if you look at what's really important, of course, is who dies from COVID. So more than half the cases, about 60% of the cases, happen in people under the age of 50. And again, given who's been tested, 98%, almost all of the cases who ultimately die are over the age of 50.
Yeah. I think that's why we've been so careful about wanting to protect our older family members and members of our community, particularly those that are in group settings. So,
I mean, over 80% of the deaths in COVID in the state of Minnesota are in nursing homes.
Yeah. So with that, there's other things about COVID that we've been starting to understand, particularly as the weeks have rolled on here. And I think one of the things that's a little bit unusual about people who've developed the serious aspects of the disease and the complications are clotting, this sort of clotting of their blood in different ways. And Dr. Nikovich, you're a bit of an expert in that. I know you were teaching our medical students just today about it. So,
yeah, it's been very interesting to observe this because an interesting phenomenon has happened with these patients with COVID infection is that they are well and then suddenly deteriorate. And it's been reminiscent of when you see a patient with a pulmonary embolism and how they can suddenly get very sick and need all manners of support to prevent them from passing away. And what's been observed clinically as well as actually in autopsy series are clots in pulmonary arteries and other vessels in patients who have succumbed to COVID. And it turns out that the COVID infection is more prone to form clots in patients compared to other patients who have septic shock, where it's more prone to bleeding. It's not well known yet the mechanisms behind all this, but yet it's a very well established thing that it's prothrombotic and meaning more prone to cause clots. There's now guidelines in place. We have at Essentia, I'm sure St. Luke's does as well, very similar ones, about if someone has COVID infection and they're seriously ill, should they get prophylactic anticoagulants? And the answer most of the time is yes. And what if they have an established clot? Should they be treated? Yes. And how should they get that? Okay. And mostly it's with heparin or drugs like that, low molecular weight heparin. We've not used drugs that block up or break up clots like we do with a stroke patient. We don't recommend to do that for patients with COVID because there's just no evidence to support it, and yet it could be very dangerous on the other hand too and cause bleeding.
So, and I know, and I understand that part of that blood clotting syndrome, it's not even just the lungs. There's been people who've lost limbs because they've had to have amputations. There's been strokes that have occurred because blood clots have traveled to the brain. So lots more to learn about this,
so
it seems
it's
like.
very much like an antiphospholipid antibody syndrome in my way of thinking about it. It's because it involves the arterial system and the venous system. And it may have some overlap in that regard. Certainly there's overlap with things like toxic shock syndrome. And probably that's where some of the mechanisms, when they're finally articulated, are going to be found to have overlap.
Well, and I think that leads me to another question, which is to say that we're seeing some unusual things, and we've heard about for the children that actually get impacted by COVID, that there may be a syndrome associated with that, with some unusual sort of appearances.
Correct.
Have you heard about that?
Well, I have. I haven't seen any children like that. However, I've heard about it. It's in the medical literature, and there's an overlap syndrome with something called Kawasaki syndrome, which is a syndrome in kids where they can have rash and also sometimes an inflammation of medium-sized arteries in the body, including the coronary arteries. Kids typically recover from that. It's thought to be virally induced. In fact, maybe by other types of coronavirus, not COVID. And there is a syndrome for this out right now where it's a multi-organ system, systemic inflammatory response. I'm forgetting the exact
but it all shuts everything down.
Right, it shuts many things down. There was originally published out of an observation from Italy where there was a huge amount of COVID infection that was published in the Lancet earlier this year. And not all the kids had COVID, but they had the same type of syndrome. I think a couple of the kids did die from it. Others survived, and it's been observed in other places of very similar types of phenomenon.
So again, plenty more to learn about this particular virus and how it behaves. And even though we've been living with this now 5 months for some, in some ways, there's just so much more to learn. So we're starting to get some viewer phone calls, and I want to combine one that came in from the email with one that's been asked here tonight because I think they could be related. So let's start with the one that came in through email that talks about the possibility of vitamin D playing a role either in preventing the virus or being related to the development of the virus. Who wants to tackle that one?
Well, this is very interesting. There's been some data out there looking that patients who have died of COVID that may have lower vitamin D levels, and that's been an observation. There's been a correlation with low vitamin D levels in patients who die of COVID, but there's no data to suggest that vitamin D levels being low is causative to COVID virus infection. And there's some nice papers written on this, and there's one out of the UK from the Center of Evidence-Based Medicine, in fact, that goes through all of this. And so there's no evidence to suggest that low vitamin D levels will predispose someone to COVID, and likewise, no evidence to suggest that vitamin D supplementation in someone who's well will protect you from COVID infection. However, there's plenty of evidence to suggest taking vitamin D is a good idea anyway. So I think so for bone health and calcium metabolism, and also for your immune system, and particularly in the northern parts of the country. So personally, I take 1,000 to 2,000 units a day of vitamin D. 2,000 units in the winter, 1,000 in the summer, because I guess I'm outside more in the summer.
Well, it's been such a beautiful day. It
Right.
sure reminds everybody to go soak up some of the sunshine. Well, and the reason why I thought this caller tonight, who's wants to know why are we speculating that the virus may decline during the summer and reemerge when it gets colder. I had seen some information about this vitamin D and how that sort of fluctuates, particularly in the northern climes, and that may be related. But Dr. McCarty, have you got anything that you know about the cyclical nature of this?
Well, for some of these, we don't know enough still about the transmission, but if it's certainly droplets, you bring people back to school especially, or people who are seasonal work and they've been outdoors and they come into close contact indoors and likely to pick it up. And kids, interestingly, we've seen that they're probably less likely to show disease when they're infected, where they've been tested. We don't have a lot of information, but bring them back together in school and they bring it home to their family members and their grandparents, who are far more likely to get sick.
Well, and so we're about to learn whether or not it's going to behave, right? Just like, yeah. So here's a real quick question. I wish I unfortunately know the answer, which is, has a cure been discovered? And the answer is?
No.
No, not yet. Prevention in this case is more than an ounce of cure. So back to wearing your mask. Here's one that's I think is something that we've learned an awful lot about at the medical school recently. This viewer wants to know, can COVID-19 exist in fecal material? And if so, can it contaminate the water supply? And I know we've recently had a couple of our scientists who've been working on a project. So.
Yeah, actively collecting data now to see if we can discover in wastewater, and then where we don't have mass screening in the community, to be able to screen water simply and pick up outbreaks before we detect them clinically.
And there are people doing this around the country in different projects, and what we've learned so far is that there is an active virus by the time it gets into into the waste or sewage area. In fact, we know that because we're allowed to bring samples into our building, which we wouldn't be able to do otherwise. It's all been, we know that it's not active, but the evidence that it's been there can be picked up based on some very rigorous testing that's done using a technique called PCR. So not only here in Duluth, but in other areas, we're starting to look at that, and hopefully we'll understand more so that we can protect our populations or know when it's active. Because one of the things, right, has been that people are shedding and don't even know, meaning that they don't feel ill, and yet they're spreading the virus.
Right, that's the whole purpose of the quarantines.
Yep.
When people travel, yeah.
So here's another caller who'd like to know if they need to sanitize their groceries and the newspaper, and if so, how? What do we think about that?
I don't think you need to do that. There's been some evidence that's come out recently that the virus actually doesn't stay long on fixed surfaces, hard surfaces, and even if you can detect it, it doesn't mean that you could actually catch the infection from it. So I think food from the grocery store, some things you wash your hands is what I would say all the time, is you wash your hands, and that's the single best thing to do, not necessarily to wash every package or anything else from the store.
Yeah. You know, one thing it sort of makes me curious, it just occurred to me that the kinds of things that we're doing right now for COVID may in fact help us have a better flu season? So we often will get a question on the show asking if, for example, if the flu vaccine can protect you from COVID, which it can't. These are two separate things. But the kinds of protections that we're doing for COVID may help us, I wonder if it will help us, lower the chances of developing influenza and other types of viral illnesses that might happen in the winter.
I would say an absolutely yes. So the same messages, the same public health messages, wash your hands, wear a mask.
Don't breathe on each other.
Yep.
Okay.
Stay home when you're ill.
Stay home when you're
Please
ill.
stay home when you're ill.
That is a big one, and I think that's always hard to do. But we certainly at the hospital. I mean, we're screened when we come in the door, right?
We're screened every day. Yes, I think every healthcare facility is going to do this: a temperature check, ask questions, and then you get a sticker that usually says the day.
Yep, day of the week.
And that's what you have to wear. In fact, when you travel across campus to gain access from the clinic to the hospital, you have to show that. Otherwise, you got to get screened again.
Yeah.
Some places are actually screening people twice a day in clinic on temperature checks.
Well, and so what I think is also important, I think another goal that we've had on the show weekly is to really remind people that if they're sick, if they feel sick, they shouldn't be around other people. But if they have a health problem, I should say something like chest pain, or they hurt themselves, or they're having abdominal pain,
they should seek care. And
they should seek care.
They should come to the ED. They should come to call your doctor and be seen in clinic. Our hospitals are probably the safest place you can be.
Yeah, I would agree with that.
Yeah.
I think it's always reassuring to see, even though as we're learning more about the existence of the virus on surfaces, the cleanliness is amazing, and and particularly how our custodial crews have gone through and really are cleaning even the door handles and the stairwells. I mean, it's been really reassuring. So. Here's an email question, is what is the average age of those who have died of COVID in Minnesota? And I think we sort of hit on that just a little bit earlier, but I know in your investigations. Do you have sort of a ballpark?
I don't have an average age, but like 98.5% are over the age of 50.
There you go.
Yeah.
And virtually every one of them died, regardless of age, have some other comorbidity.
Right. And
one or more.
And those are things like, and we've talked a lot about that on the show too, diabetes, kidney disease, COPD, other kinds of health problems. Now, Dr. Nikovich, I know you're an oncologist, and we had Dr. Sandy on last week, and he had talked a little bit about how care has been able to be continued. What kind of protections, are there any extra protections that the cancer patients are receiving? Because they've continued their care through this, right?
Yeah, we've continued without interruption. So we've done a lot of the things that we just keep doing with what we've been doing. So there's, fastidious hand washing. We wear masks. We wear goggles of some sort always. If there's any hint that someone may be infected, we have another protocol where we get into gowns and gloves and sort of full protection gear if necessary. Our nurses all do the same. And that's how we've been able to protect everyone and keep everybody well, and in fact to keep it all running on schedule. It hasn't really slowed us down. There was some thought about that. This is going to add time, and we're not going to be able to see as many patients in it. That hasn't happened. What has happened, unfortunately, is that we can't have all the family in, and that's been a key thing, I suppose, that's changed. Right. We have allowed a spouse to come in when there's an important conversation to have about the results of a test.
Okay.
In the hospital, we've allowed a spouse to come in when someone's not doing well, and maybe they have only a few days to live or something like that. But as a routine matter, when all the family can come in on Sunday afternoon after church, that doesn't happen anymore.
Yeah.
And I think actually that's been really important to reducing the spread of infection, although obviously it's caused some issues. Now, we have done a lot of work with tablets and iPads that are available in the hospital, so you can connect in some way and see your loved ones. So a lot of those things have happened. And then, of course, everything we've done with our virtual visits.
Right.
That occur in the cancer center as well as in all parts of our clinical enterprise.
Well, and I think that's something we're really learning a lot about with that virtual visit. And in fact, particularly given the areas that we serve, and particularly for those folks that are watching the show, often they're traveling quite a distance to be able to receive their care. And this has actually sort of pushed us into a space that we might be able to continue this kind of service for patients, because it's been very helpful, I think, to not only be able to offer that to them to save them the travel time, but also to protect them when they're not, or maybe when they're not feeling well for whatever reason, particularly if they're a cancer patient. You know, they may have gotten chemotherapy, they don't feel well, but they still have to go see the doctor. But in this case, it's easier to allow them to sort of be comfortable in their home, and we can do those virtual visits.
Right, so now we're able to do it the way we've always wanted, literally from the kitchen table.
Literally.
And hopefully that patient has broadband access, and you can use things like Zoom. Not every place in the rural community has that.
Right.
The real game changer with all this virtual medicine was that Medicare and other insurance payers now cover that and pay for that, whereas previously they did not, and that was always the impediment.
Yep. So that's something to look for that will take a silver lining perhaps away from all of this pandemic.
It's not going away, Paula.
No.
It's here to stay.
I agree.
Yeah.
So here's a simple question. Will flu shots be distributed as usual this fall, and should people get them?
Yes and yes.
Yes.
Yes and yes.
Absolutely, yes and
Right.
yes.
Yes.
Okay. And then I would say, I think we often hear a little bit about how people are stressed right now. And so in the last few seconds here that we have of the show, just a reminder that for individuals who may be feeling additionally stressed, have depressive symptoms, et cetera, please call your primary care doctor and look for the hotlines at the hospitals. We're here to help. So I want to thank our panelists, Dr. Kathy McCarty and Dr. Daniel Nikovich, and our phone staff and crew for being here this evening, and for our viewers for being engaged and with your questions. Please join me again next week for our final show of this special series of programs on the pandemic, when our guests will be Dr. Rajesh Prabhu and Dr. Nick Van Deelen. It'll be nice to have them back to talk further about what they've learned. Let's do our part to keep this pandemic manageable, continue to practice physical distancing, wash your hands, and sanitize touch surfaces.